Okay, this microphone is working, so I will be much easier. I think so. The next session, I'll be introducing about some make a brief introduction about the respiratory diseases. So, as I am a chest physician, so just first of all, I would like to show you what's the position of the respiratory disease in China. So this slide shows the 5 leading causes causing death in China in the year 2010. So this is in the city area, and this is in the rural area. So rural area. So this is disease, of course. Everybody knows. So malignant tumor ranked the first, both in the city and in the rural area. So second is So the first in the city. So this the second with the heart disease, low coronary heart disease, and some others. The third was cerebral vascular disease. This is quite common in China. So it's much more as compared with the Western countries. So the respiratory disease rank number 4. And then there's some trauma and poisoning. In the rural area, cerebral vascular diseases is the rank number 1. And the second, malignant tumor. And third, heart diseases and respiratory diseases rank number 4. So in other words, in the top 5 disease, respiratory disease is a very important diseases, make a great impact of public health in China. So for example, just give you, so just now I mentioned a lot about the chronic respiratory, chronic obstructive pulmonary disease, 慢性阻塞性肺疾病. The prevalence of chronic, we call it COPD, is 8.2% in the population older than 40, right? So this, in other words, goes to 33 millions, more than 33 millions of the people in China suffering from COPD. And asthma is really increasing. And 20 years ago, it's about 1%. Now it's 1.2%. So altogether, we'll be 15 million patients in the world. And also, this data is coming from WHO. So each year, we have 1.6 million patients died in China because of basically COPD. This is one chronic respiratory diseases. And the second point is a big problem is tuberculosis. This is also a very serious problem in China. So the newest prevalence survey is in 2010. The prevalence of 459 per 100,000. This is quite high. It's the second largest TB country in the world, just follow India. So in other words, 1 million, we have 1 million new patients occurred each year, accounting for 14.3% of the whole patient in the world. So, and also one thing which really worried about the physician is it's getting higher and higher the incidence of multi-drug resistance TB, multi-drug resistant, 耐多药. It varies from places to places, from 6 to something like 10 or something. So that's the second point. And the third point is, so that's the newest data from annual reports of cancer in China. So you can see lung cancer ranked the first in China. So the tendency of lung cancer prevalence is high incidence, higher mortality, and younger age. So to my experience, the youngest age I met is a girl, so 13-year-old, 13 岁. So that's a big problem. And then number one, and then lung cancer predominantly in male rather than female. It's 1.68 versus 1. So this is one thing. And this is the data, I just get it from the 10 days ago from the People's Congress. I attended People's Congress. And this is from Beijing, my colleagues. And this is the data from the year 2010. You can see in male and female. In male, lung cancer ranked the first, very high, 76 per 100,000, pretty high in the world. And also in female, so breast cancer, of course, ranked number first, and then lung cancer ranked the second, is also pretty high. This is really worried about that because of different reasons. I'll tell you later on. So this is the second part of cancer and chronic respiratory disease, and also virus infection. Just now I mentioned. One is SARS. Everybody just now I mentioned a lot. So in the world, about more than 8,000 people suffered, and then nearly more than 900 died. In particular, in China, mainland, Taiwan, and Hong Kong. And this is another flu. It's called avian flu, 禽流感. And then this is a lady from Anhui in a small village, and she actually ate some sick chicken, and then got sick, and then got disease, and she eventually died. So this is the data that's from WHO in the year 2009. So here, so that's avian flu. Here is in China. So at that time, so 25 out of 38 died. So you can see the mortality, the death rate is pretty high. So you can see here, so as a whole in the world, so 256 out of 411 died. The percentage will be 62%. Wow, that's really high mortality. So avian flu is a really frightening disease in the world. So I don't know whether you have noticed the news recently. This is this is H1N1, or called a swine flu. It's a 猪流感. It's coming from Mexico. So that's the data. But I don't think that data is very precise. You see, in China, it's about more than 1,200,000 confirmed, and more than 700 died. And globally, 100 million cases, and this is the death rate. So this is swine flu. We call that 猪流感. And recently, so you can see some new coronavirus infection. This coronavirus is the same type of SARS, but that's called SARS new coronavirus. This new coronavirus is very similar to SARS, but the subgroup, the gene sequential analysis, a little bit different. So from the April 2012 to the 13th March this year, that's just a couple of days ago. So 15 cases of new coronavirus infection, including patients from Saudi Arabia, Jordan, United Kingdom, and Germany. So of course the death rate is still pretty high, 60%. 9 died, 9 out of 15. So in other words, respiratory disease is still a big problem and causing a big impact to the health of humans' health. So the second point I would like to mention about the structure and function of the lung. And just a brief review about that. I suppose everybody had learned that. So this is lung, the left lung and right lung, 2 lobes, upper lobe, lingular lobe, lower lobe, right upper lobe, middle lobe, or lower lobe. And this is everybody knows that this is the trachea and bronchi. And this angle is rather blunt. It's 钝角, blunt. So from the right bronchi. So this is why the foreign body coming inside is very easier to go inside to the right bronchi rather than left side. And also this is a oval shape with the semi-cartilage and with some membrane covering in behind. This is a trachea. And then the airway is divided into 23 generations. The 23 generation. This is bronchi, and going to the bronchioles, and then the alveolar ducts and respiratory bronchioles. So this is also have some respiratory function, so gas exchange function, and also this so-called alveolar ducts, and then alveolar sac. So altogether 23 generations, and this is all you know very well. So actually the epithelium is very special in the airway. We call that pseudo-stratified ciliated columnar epithelium, 假腐层柱状上皮. This is quite different. So quite special. So you can see if you look at this so-called pseudo-stratified ciliated columnar epithelium, you can see this is gallbladder cells secreting some mucus. So the mucus covering on the surface of the airway, and this is a cilia colon cells. So with cilia and keep moving all the time. So foreign body or foreign particles or pathogens will stuck in the mucus and moving by the shaping of the cilia when going to the throat and push out, cough out. So this is some the so-called very special pseudo-stratified ciliated columnar epithelium. And this is alveolar. You can see this alveolar wall. It consists of type 1 alveolar cells, and this is consists of that. And also this is type 2 alveolar cells producing some surfactants, 表面活性 surfactant, which keep the alveolar open. So keep that open. In the newborn infant, sometimes the lack of this surfactant, that's alveolar collapse, right? So this is a macrophage. So it's have some function of phagocytosis, 吞噬功能, phagocytosis, and kill the pathogen and virus and so on. This is the lung. And then, and also, so swallow the particle, dust. And then, so this is why I always mention about a smoker and people long-term living in the airway pollution will keep the lung black like that. And this interstitial, this capillary, with some gas exchange in between alveolar and capillary vessel. Okay, as you know, the lung was supplied by two blood system. One is pulmonary artery blood. Another one is bronchial artery blood. So by two ways. As you know, pulmonary artery blood is blue one, is venous blood, and when passing the alveolar will change into the arterial blood, and bronchial blood as a arterial blood will supply the both ways supply the alveolar and bronchus and bronchiola. That's the whole structure, very brief. So I would like to talk a little bit about the character of the pulmonary circulation. So as compared with the systematic circulation, it shows a low pressure, low resistance, and high blood flow. So in some of the disease, like heart disease, like you'll be studying on the heart disease, rheumatic heart disease, in particular mitral stenosis, 二尖瓣狭窄, we call, or some others like left ventricular insufficiency because of hypertension, hypertensive heart disease. That's what we call some increased pulmonary capillary pressure. It is increased high enough, the liquid will go from the blood vessel into the interstitial and then to the alveolar. So that's called pulmonary interstitial edema and pulmonary alveolar edema, 肺水肿. Okay, but this is the main road. Another road, quite often, it's will exaggerate this edema. It's called hypoproteinemia, 低蛋白血症. But because of liver disease like cirrhosis, because of kidney disease like renal syndrome, the nephrotic syndrome, will cause decrease of plasma osmotic pressure. So when the plasma osmotic pressure going down, so the water or liquid will going up, will go outside the vessel, and cause an exacerbate the pulmonary interstitial edema and eventually cause some pulmonary edema. So this is one thing is very important in terms of the pulmonary circulation. So I would like to talk about the architecture and function, how to link together about the airway, because as you know, lung is open to the world, to the environment. It doesn't like heart, doesn't like liver. It's closed inside the body. But lung is with a lot of interaction with the environment. So as you know, the total respiratory area for each people will be about 100 square meters, very, very big, 像足球场, but as usually in the environment, we have some inorganic or organic or allergen and harmful gas or microorganisms inhalation into the lung. And on the other part, we have some defense effect. That's some physical and chemical and biological defense. That's, the physical heating or filtering, filtering from the nose and cough out the foreign body and particles and sneezing. And also, just now I mentioned mucociliary transportation. That's really important. Every day, so mucociliary is going up, put the mucus up to the nose, to the throat, and then you cough up. So that's very important. And also some biological function. For example, just now I mentioned about macrophages have the function of so-called phagocytosis, 吞噬功能, phagocytosis. This can kill the pathogens. And also, in particular, in some immunoglobulin, in IgA, and can kill the pathogens. So that's interact in between every day. So make the balance that keep the body in health condition. But the point is, when the environment is really bad, we have a lot of risk factors. What happens to the heart, to the lung? You can see everybody, everybody will breathe about 20,000 times a day. Everybody. So we'll have the exchange of the air, of the gas, about 10,000 liters. So everybody will have this. So you can see if the environment has some pollution or some other things, you will have a big harmful, a big damage to the lung. So you can see the risk factors relate to the respiratory diseases, like dust, like sulfur dioxide, smoke, and cotton dust, 粘尘, and silica oxide, or industrial waste gas, or carbon monoxide, nitrogen oxide, hazy sky, something like that. That's 灰霾天. Or always would like to most, because too much foreign agent. And then the lung cannot defend enough, and then cause some diseases like chronic bronchitis and COPD and the so-called pneumoconiosis, right? 尘肺 and silicosis, and some lung cancer in particular, and some asthma as well. So this is one thing, the very important is air pollution and smoking. I'll talk a little bit more about this. So this, as you know, in my age, like you, a lot of this kind of smoke. But now it's much better than before. But now the point is, so still have coal mine burning, and then some exhausted gas from the car, from the automobile. It's not reaching the criteria. So this is what I appeared. So this is why now we are very much concerned about the PM 2.5. What does it mean, PM 2.5? That's the particles with the diameter 2.5 micrometer, which is easier to enter the alveoli, 一直到肺泡里头去. So that's why it can cause more damage to the lung. So you can see this is data of the world, the PM 2.5. You can see this is China, and this is mid and east part of China. Beijing is down here. That's the worst, air pollution in China. So this is I took a picture from the newspaper and Xinhua Wang. That's only last month. That's in Beijing. This is the picture. This is the same picture. You can see. This is a hazy sky. You can see here is, and you can see the people. So using mask and all the things is terrible at that time. This is in Guangzhou. So this paper, this actually I took that from the Arsha Dao. You can see the same thing. It's Guangzhou a little bit better, but not really good as compared with the other part of the world. So I just show you what the harmful effect of PM 2.5. This is one data from Dr. Guo from the Chinese University of Hong Kong. So she published a paper and said each increase of 10 microgram per cubic meter of PM 2.5 will cause 3.1% of emission of COPD patients. This is one fact. Another fact is just published not too long in the United States is showing the long-term particle pollution and lung cancer, the relationship in between that. They have, this is a very good study. They have follow up for 26 years. So big long-term study. So follow up 1,100 lung cancer patients. And they have found each 10 microgram per cubic meter increase of PM 2.5 concentration was associated with 15 to 27 increase in lung cancer mortality. It's very convinced, and I can show you a lot from Japan, from Denmark, and from other countries, but we don't have correct, solid data in China. So this is one thing, air pollution. And the second point is smoking. As you know, smoking, everybody knows, is very high in China. From this prevalence, the third prevalence is 48, close to 50 in male and 2.6 in female. It's a very high population in China. So they will increase the chronic bronchitis or COPD 2 to 4 volts. In particular, increase lung cancer to 4 to 10 volts. It's very, very high. So this data, I like that very much. That's from Pitto. He actually published this data. That's 50 years follow-up in the British Medical Journal. And this is younger, this is older. This is the smoking rate is going down. And the early 50s is pretty high, even higher in China. So it's going down. And the lung cancer mortality is going up and then now going down. So it's now much lower than in China. So this is very convincing, showing the relation in between smoking and lung cancer, that tendency. So smoking is a big problem, but still now in China is not a lot of publicity showing the smoking is how good it is. So that's very important. We have arguing about the publicity by the tobacco company. So they're always saying the low tar, low risk. And also they earn a lot of money, 赚了很多钱，什么中药、神农茶、什么神农草叶什么。This is a great fraud. So it's not a science, it's a fraud. So this is everybody do not believe that. That's the first point: air pollution, and the second point will be this one. This is some allergens. You have more information and when the cause is asthma. Mite is the main cause. Mold, cat, and pollen, and so on. And of course, the third is bacterial, virus, and some other pathogens. I'm not going to talk too much about that. It's we call that two kind of pneumonia. So one is community-acquired pneumonia, or pulmonary infection, and the second is hospital-acquired pulmonary infection. That will have a different kind of bacteria, and in addition to bacteria, and you also have some mycoplasma, chlamydia, and virus, and mycobacterial tuberculosis are also. This is the third one. This is a virus, SARS coronavirus, and this is H5N1, and so on. So now I would like to talk a bit about the diagnosis. So first of all, I think history is very, very important. You should collect the history very carefully. For example, if you had a patient saying when he got worse, chest tightness, so after inhale some dust, pollen or hay, and why he performed intensive exercise, sport, will have very severe dyspnea. That will give you a clue if patient may have some asthma. And this patient, if they have some history of heavy smoking, so you should think about this patient may have COPD or lung cancer. And also this is very, very special. And I have met a lot of patients like this. Consumption of uncooked gray fish, a snake goat, 蛇胆, and then land tortoise blood. In particular in Hainan Dao, I met a lot of patients coming to see me. This is actually some parasite infection. So like pulmonary dystomatosis and strongyliasis. This is 肺吸虫 and 管形线虫, this. And also you should ask this history, because if the patient had hypertension, he takes some medicine, antihypertensive. In particular, angiotensin converting enzyme inhibitor. Sometimes about 20% will develop cough, very severe cough. If you stop this medicine, okay, cough's gone. So this is very important to ask the history, all right. And also the other things like this avian flu. So if the patient contact with the dead birds, so you should pay more attention about that. So symptoms, altogether symptoms will have 5 symptoms: cough, sputum, breathlessness, or dyspnea, and hemoptysis, and chest pain. So cough is we should think. I would always like asking him in detail about cough. What kind of cough? If acute fever with hoarse voice in young men, of course, acute bronchitis. If acute fever accompanied with bloody sputum, well, you have to take an X-ray whether they have pneumonia. If the patient would have cough only in midnight or early morning, and then in daytime it's okay. So at this time you should be very aware about this patient may have bronchial asthma, 有哮喘, right? Of this patient with persistent worsening cough and dyspnea may have lung cancer, idiopathic pulmonary fibrosis, or COPD. These symptoms, that's cough. That secondary is phlegm, we call sputum or expectoration. So if the patient's from white to yellow, maybe bacterial infection. And if the patient with massive purulent sputum over a long time, like this, 3 layers, so purulent, and then mucus, and then so water-like liquid, the 3 layers, that's typical bronchiectasis. So if the patient like this, this will be jelly-like, maybe some parasite or pneumonia. And if the patient cough out, they said they have some like a cast without cast. So the cast, 管型 cast. Oh, you should be aware. This patient may be you have some allergic disease, bronchial asthma or some fungus infection. Yes. The third is hemolysis. Hemolysis, you should think about whether it is a huge amount or bloody sputum or small amount and so on. So should give you some information about that. If you have sudden burst of massive fresh blood, but probably this patient, the majority of patients may be 2 kinds. One is bronchiectasis, another one is tuberculosis. And tuberculosis is not common now in China. But when I was in intern, 我是一个实习生的时候, 40 years ago, so more than 40 years ago, I met a lot of patients like this, a huge amount of cough out. And then the patient get apnea. You know apnea? 窒息 apnea. And the patient died. And it eventually found that patient actually had tuberculosis. So small amount of bloody sputum over a period should be very aware about the patient who have lung cancer. And then bloody sputum with very severe chest pain should be aware whether this patient had pulmonary embolism. So this is hemolysis. And the fourth is dyspnea. So 呼吸困难. So it said that acute dyspnea is acute pneumonia, pneumothorax. This is very common. 气胸 will have a dyspnea. And of course, pulmonary edema or some others. Some chronic will be COPD or idiopathic pulmonary fibrosis. We have to notice whether this patient is dyspnea during inspiration or during expiration. If the patient had some dyspnea inspiration, this kind, it must be something wrong with the upper airway, like laryngitis or laryngeal edema or something like that. It's expiratory, like this. That must be bronchial asthma. So sometimes if you inquire carefully about the patient's situation, you can get some clue of diagnosis. The final is chest pain. So as you know, the pleural will be 2 layers. One is visceral and another is peripheral, right? Visceral, peripheral. Only peripheral was involved. The patient will feel pain. Visceral, there's no pain feeling. So like pleurisy, pulmonary embolism, pneumonia, lung cancer, pneumothorax, always will be pain. But chest pain is quite complex. Everybody should be noticed. So not only in the lung, but also, you know, the heart is in the, also in the chest, in the thoracic cage. And also, please, gallbladder. So, gallbladder, that cause some cystitis, cystitis. So that will also cause chest pain. So the signs, so you have learned from basic diagnosis, the cause. So like rate, rhythm, depth, location of bronchus, whether it is symmetry of the thoracic cages. So percussion, auscultation, and there's a rhonchi, a moist, roused. And this is really important. If this patient have inspiratory plus expiratory moist, roused, maybe this patient would have bronchiectasis. If patient just have a fine rouse in the right, both or right or one side of the lower lung, will have pneumonia. If this, you can go to the ward and listen to this crepitation, 连法音, sa 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 sa, 连法音. This patient have a very special, it's called interstitial lung disease. This is very common now. So some other, if you can, during oscillation, you can listen to the bronchial breathing sound. That will consolidation of the lung. And then some others. That's science. Laboratory examination should be noticed. So some essential examination. Imaging, so ultrasound, radiology, and also lung function test and fibrotic bronchoscopy. These three is essential for the, of course, this you understand, CT, and this bronchoscopy, and this is under the bronchoscopy. It's quite common. We found a tumor here, so easy to find it out, to do a biopsy and see what kind of disease it is. And this is a lung function test. It's easy to perform, but very difficult to perform precise lung function. So now we have more training for this, for all the medical staff in whole China, to train them to perform lung function test. Because lung function is very important to differentiate obstructive or restrictive. If it is obstructive, maybe COPD or more. So that's a decrease by FEV1. And if it is restrictive, it's decreased by FVC. This, you probably know more about that. So also lung function can detect the patient. So the severity of lung function, and then to know the patient whether it is available to receive the operation or not. So the future of the management, again, I mentioned in the last session, I mentioned about 5 models. It's very, I have a great hope to you. So, but because nowadays in most of the doctors are not very aware about this. So we have to go this way. Predictive, preventive, pre-symptomatic, and personalized and participatory. Blood pressure going up, even without symptoms, we should give treatment. So coronary heart disease, if the blood cholesterol going up, the glycerin is going up, even without symptoms, we should give a treatment. Diabetes, we should give when the blood glucose, not sugar, glucose going up, we should give a treat. Not treat until the patients develop stroke, 脑出血, myocardial infarction, 心肌梗塞. That's too late. It's not good for the doctor. So that's why in COPD, respiratory disease, now very backward, 非常落后 in the world. So only the patient had breathlessness, the patient can have some treatment. But when the patient developed breathlessness, 气短, the lung function had impaired about 50%. This is what I hope need you to do that, to do some research about it. Whether the annual decline of FEV1 will be helpful to have an early intervention, early treatment. So this is our work from 2002 to 2007. This is normal decline of annual DMO in normal person. This is smoker. This is COPD non-smoker. This is COPD smokers. Actually, when the lung function decline to some extent, the patient will have dyspnea. So why we should find this change earlier and then give them some treatment earlier. So this is why we should treat. We don't treat this patient in the early stage rather than in the late stage. It's too late to us. So a lot of facilities available for detecting the early stage of cancer or some others. So this is our future to do. Finally, I would like to talk a little bit about individual treatment. So take an example to do so. Cancer, non-small cell lung cancer. We just find out the mutation of EGFR. EGFR, that means epithelium growth factor receptor. If this EGFR have mutation, if we give the EGFR inhibitor as geneticist, so the survival will be increased, survival rate. This is this is standard treatment. If it is negative, mutation is negative, the survival will be decreased. So that's help us to give some individual treatment. So I would like to finish this. Thank you very much for your attention.